You're live now.
Welcome you all to yet another edition of Public Health Biographies. This, as you know, will feature scholars and activists who have shown their eminence and created footprints on their professional journey for others to follow. I am K. Rajashekharan Nair from the Global Institute of Public Health, and my co-host is Dr. Mohammed Shafi from the University of Boston. And we hope a follow-up of their trajectory would help the present and future generations of public health scholars by providing many useful and rich insights. Today, we are happy to welcome Dr. N Devadasan, co-founder and former director of Institute of Public Health in Bangalore, to this series. And I understand, Dr. Devadasan, you started your career as a community health doctor in the forests of Nilgiris, and you worked with the Adivasis of Gudallur for about 10 years, building a comprehensive health system for them. I mean, on a lighter note, I'm sure you found your name meaningful while working there as a real Deva for the tribals and a Dasan for of such underprivileged communities. And this is an incredible start. I mean, I would say, and this would have helped in shaping your public health perspectives. And also, this is unlike many public health scholars of the present who start sitting in the front of computer. I think I will ask you, can you narrate your long experience here?
First of all, thank you very much, Professor Nair and Shafi and GIPH for giving me this opportunity and inviting me for this series. It's an honor to be here and to address all of you all. So as Professor Nair said, requested, I was essentially a city boy. I was born in Kerala, but then I grew up in Calcutta for 19 years. I was there. Except that because of certain personal incidences, I wanted to work in a rural area, in a needy area. I got admission in CMC Vellore, and that was further strengthened my resolve because the spirit of service was kindled further over there. And of course, my professors in community medicine, Professor Benjamin and Professor Abraham Joseph, were really instrumental in guiding me to take up this, to take up community health in a big way. They taught me not only the skills, but also the attitude on how to work. And then the third point was I met my life partner, Rupa, over there. And I think that was also a big turning point for me because now there were two of us who wanted to go and work in the rural areas. So soon after marriage in May 1987, we had about 6 months before the postgraduate exams. So we said, okay, let's go and work somewhere for a few months, and then we'll come back to Vellore to do the post-graduation. So a friend of ours pointed us to Gudallur in the Nilgiris. This is a taluk bordering the Mudumalai sanctuary. They said there is a couple over there working for land rights, Adivasi land rights. They want somebody to help them with health. Can you go and visit and see if you can help them? So in June 24th, 1987, I still remember the date. It was kind of a turning point in our lives. We went to Gudallur, and it was really, our life changed after that. We were exposed to Kaniyambadi block of Vellore, where because of Chad influence, everything was very, perfect. There were immunization rates were 90%, etc., etc. And here were this group of people in Gudallur, the Adivasis, who were totally sidelined by the mainstream society. They were not even on the records of the government health systems because their villages, their hamlets and all were too interior. So the ANMs would not go into those villages to enumerate them, etc. And when we went into those villages, we noticed mortality at an unprecedented scale. Women dying due to pregnancy, infants dying because of pneumonia, diarrhea, dehydration, etc., which really shook us up. And then we felt that RPGs can wait, but the lives of these people cannot. So we took a hard decision at that point, saying that let us continue to work here for some more time and build up health services whereby they can get basic health care. So we started with community health workers, training community health workers in each of the villages. These were Adivasi women, most of them were illiterate, but we used different drama, role play, pictures, etc., to teach them how to do antenatal checkups, to treat common wounds or diarrhea or fever, etc. So, that was the first stage. But during that stage, what we realized was that when providing this sort of care meant also having a good referral center, because we would go to the villages to supervise the health workers, and there they would say, this child who we have immunized fully, she's got now pneumonia, she's got a breathlessness, so it's pneumonia and needs admission. And then we would take that child to the government hospital, 100-bedded hospital in Taluk Hospital in Gudlu town, but with very little resources, hardly any doctors, only 2 doctors who were always in the OP and never in the wards, no medicines, nothing. I'm talking of the Tamil Nadu of 1987. So we would send these children there, or we would send these adults there, and they would just die because of lack of proper care. And slowly over the time, more and more people from the community started demanding that, okay, you're doing all this very well, community health workers, our women, etc., but we need our own hospital where we can send our people. And that's how, from a community health program, we realized the importance of a referral center, and we started a small hospital. Initially, it was only 10 beds. Now it has grown to more than 50 beds with all the facilities. Then, while we were doing this, health center and the community health work and the hospital, people again came back to us saying that, listen, for a fever, the health worker gives us paracetamol. But if we have a cough, then she says, please go to the hospital. And that is 3 hours away from our village. Can't we have somebody in between who will can treat these sort of ailments? Do we have to travel 3 hours to the hospital just to get a few more tablets, this thing? And that's when the whole concept of, okay, maybe we should have a medical assistant or a nursing assistant equivalent and a decentralized health center. What today the government of India talks of health and wellness centers for 5,000 population. So that's how, again, this idea came from the people, and we looked at it and we felt it was a very good suggestion. And then we took 1 year to train these nursing assistants. And then today, when you mentioned we have a health system, so we have at the village level health workers who take care of the basic preventive as well as minor ailment, treatment of minor ailments. Then we have a health center where there's a nursing assistant who takes care of most of your ambulatory care, as well as provides immunization, ANC checkups, all that. and can even admit somebody for observation for a few hours. They got moderate diarrhea, needs some IV infusion, or a wound which needs plastering. Those sort of things can be done. And then if that cannot be handled, then they are referred to the Gudlur Adivasi Hospital at the Taluk headquarters. So this is the way we managed the whole thing over the 10 years that my wife and I were there. And one interesting thing which I would like to point out, the thing was that most of the system is managed by the Adivasis themselves. So the health workers are Adivasis, the nursing assistants are 10 standard failed Adivasi youth who we trained over 1 year. The nurses in the hospital, most of them are also Adivasi youth who have not cleared their 12th standard, who failed at 12th standard, but again, we trained them in nursing, etc. Today, after whatever, 20 odd years, 25 years, there are nurses, young nursing graduates who have completed their formal nursing courses, Adivasis, who have come back and are working in this hospital. But in the beginning years, it was totally only Adivasi youth who managed the entire health program in this thing. And before I conclude on this, I just want to say this health program was embedded within a larger development program, where there was one wing which was very activist and was more fighting for the Adivasi land rights and forest rights. At the same time, there was a development wing which was promoting income generation, education for the children. So it was a kind of a comprehensive thing. We were very lucky to go into an NGO which had that comprehensive vision, and we played the health role in this. You're muted. Professor Nair, you're muted.
Yeah, that sort of sums up the initial experiences that you have gone through. Now, health of the underprivileged communities is still a matter of concern. I mean, even after so many years of programs specifically targeted on them. I mean, and probably in some of the tribal-dominated states like Jharkhand and many northern states also. Maybe we need a more focused attention, and for WHO also. I mean, now I think in recent times, because of the emphasis on social determinants, Commission on Social Determinants, to which some of us were associated. This has become a priority area. So what are your reflections on this?
Yeah, so there are some things which we, I mean, it is not just tribal health, it is also for vulnerable groups, whether it is the minorities. In India, we are talking of the Muslim population in certain areas. You talk about the SC population in certain states, etc. All of them have the same face similar thing in terms of they are, like you use the word targeted. They are targeted by a mainstream health system services to which they don't have much connect. And they are told to do certain things which they don't understand by people who have no understanding of their culture, their needs, etc. So that is one of the reasons why, like I said, we used health workers and nurses who were from within the community, because they understood the people, their needs, and they spoke the same language. So we assume that just because in Jharkhand, everybody speaks Hindi, so Hindi nurse A&M is good enough. But many of the Jharkhand tribals speak Santali, or they speak Ho, which is very different from Hindi. So if you can get, one of the things we have been saying right from the beginning is that for such services, I'm taking the example of tribals, but it applies to others also, we need to have people from within those communities, not outsiders who come in and say, do this, do that, get vaccinated, etc. But people who understand that. I think that is something very important. The second thing which I cannot overemphasize is the fact that we need to listen to these people. Many times, 10 years in Goodlore and subsequently also, I've heard people saying, oh, but these are illiterate people. How can you work with them? And my response is, do not confuse illiteracy with poor capacity. These are people who have tremendous experience and tremendous wisdom. Listen to them and they will tell you the answers of how to do it. How to do what and what is this thing. Instead of which we come into the community and we think that we know all the answers because EPI, the immunization program says polio at 0 dose, then DPT, OPV, then measles. In fact, when we started immunization among the Adivasis, the people just refused, saying that, listen, my child is fine and healthy. Then you come in and give one injection. After that, next day, the child gets fever. You're making my child sick. Why should I give my child up to you for immunization? Very valid, because DPT produces fever. So then we actually turned the entire EPI schedule and said, okay, anybody above 6 months, we will immunize with measles. Now, measles is a very safe thing. It's just a one-time this thing. There's no need for a second dose, booster dose, etc. And measles was a problem in that Adivasi community. So once we changed that and we started giving measles, and within a year, mothers started saying, oh, this year the measles, there was no measles epidemic in this thing. They slowly started saying, okay, maybe now we will give the polio drops or we will give this thing. So no, that is how we need to change what is centrally imposed to the needs of the society. That is second thing. Third thing I would say is we underestimate this thing of affordability, because most of us come from middle class families and we are able to fund a lot of our expenses, including our medical expenses. We assume that paying that people will also be able to pay for their outpatient services or their hospital. And both of us, my wife and I, realized very early in the thing that people may not even have that ₹1 registration fee to come to the clinic for services. Because for 3 days, they've not gone for work and they don't have any money. They've used up what little money for their food and they're just lying there on the balcony waiting for hopefully the fever to get up better and etc. So that's how we started this whole thing called, what now is called health insurance. But basically it was a prepayment mechanism where people paid when they were healthy and able to pay. And then we pooled that money and used it when they fell sick. And this suddenly we realized worked very well even among this quote unquote illiterate population. And we realized that people are happy with such a system. And that's how my interest in financing mechanism where people do not have to pay at the point of care was generated. And yeah.
But are there any difference of opinion regarding insurance? Like this universal health coverage. The 3 A's of affordability is given so much focus, and some insurance companies are utilizing and misusing that emphasis.
Yes,
that's also true.
Yeah. So like any intervention, there are people who can use it properly, and then there are people who abuse the system. So actually, lot of I am supposed to be called the health insurance expert in India in these fields because I did my PhD in health insurance and this thing. But for me, it is not health insurance part of it. That insurance label is not there, but it is about how do we make healthcare affordable to the people. And insurance or tax-based are two ways of doing it. So tax-based is when people pay tax and then that is collected by the government and used for the same. Insurance is where people pay a contribution, and that contribution is collected by a organization or an insurance company and then used for this thing. Now, there is enough and more evidence that health insurance per se, I'm not talking of private for-profit health insurance, which is common in the US, but in most other countries, like the Western European countries, etc., health insurance is seen is a non-for-profit venture. You cannot have a for-profit health insurance. The government has passed acts saying that if you are having a health insurance program or a product, it has to be not-for-profit. And these sort of not-for-profit products have really improved the healthcare status of the people by increased utilization and better quality of care. In fact, if you look at the history of health insurance came from the socialist movement in Germany, where the industrial workers could not afford to fall sick. And so they started pulling in money every week when they got their wages into a sickness fund. And then when somebody fell sick within the factory, that fund was used. So that was the origin of the insurance as we now know it. Unfortunately, the private capitalist industry took it over, especially in the US, and abused it and made it for profit, and then all the problems with it came. But today, most of Western Europe, some parts of Africa, etc., are financed by health insurance, but not for profit health insurance.
Well, you mentioned about your PhD. I think you did it from
Ghent
Institute
University
of Tropical Medicine and Antwerp.
Yes.
I think Belgium, isn't it?
Belgium.
Yeah. Yes. I just wanted to ask you, I mean, this tropical medicine tag, I mean, it's still very, I mean, it's lingering on. I mean, isn't it? I mean, we have London School of Hygiene and Tropical Medicine. And also, I mean, because it started, it's a colonial tag, I think. I mean,
absolutely. Yeah.
But we have a different vision of public health. I think you co-founded Institute of Public Health in Bangalore. And what are your views and insights on the current status of public health education in the country? I think that would be very interesting, because we have set up a different trajectory of public health education, unlike these institutes where they want to work in Congo or I mean in Africa or India or maybe some underdeveloped countries and publish papers. Unlike that, we have a different way of looking at public health, isn't it? I think
absolutely.
We want yes.
Yeah. So, in fact, just to take a step back, when in 2005, when some of us founded Institute of Public Health, it was precisely because of this. Because at that point in time, I was in the WHO for 3 years, and that gave me a tremendous opportunity to visit various states, work with the state governments, etc. And everywhere I realized that there was hardly any evidence-based policies or programs. It was all opinion-based. So the health secretary would say, yes, we should do like this. Okay, we will do it like that. Or the director of health services will say, this is how we will have to do. We will do it like that. So one was lack of evidence. And especially Indian evidence, forget about state level evidence, even evidence from the country. Two was, there were a lot of people who wanted to do such sort of research or wanted to learn more about public health, but there were very few good public health institutions. They said, we would like to join an institution where we can do such sort of research, etc. Youngsters especially, and that's how IPH was found. And two things we said. One is to generate evidence-based policies and these things, and the second one was about providing a platform for young researchers and public health professionals so that they can follow their dream in public health. Because many of them were saying that, listen, I go to community medicine department, I am just told, teach the students about sanitation and latrine, etc. There's nothing challenging there. So this is how IPH was formed. And right from the beginning, it was that we will work with the governments, state government. Initially, it was we will work with the various state governments, and we realized we didn't have the bandwidth for that. So we stuck to only Karnataka in earlier days. But we said we'll work with the state government and we'll try and improve, strengthen the health system. And when I say health system, it's not just the services, but also the financing, the governance, the human resource recruitment, etc. So this was the this thing about the logic by which we started IPH. Like you said, it was to serve the country, this thing. Whereas I agree with you totally that many of the quote unquote tropical medicine institutions are still in a phase where they want to come down, do some studies and go back and publish papers. I know it may sound a little funny, but I found my experience with the Institute of Tropical Medicine in Antwerp was very different because they are people, the faculty there have all lived in Congo for decades. So they have tremendous experience on the ground. And that's how when I did my MPH, I was thinking, what will, after 10 years in Goodloor, what will these people teach me about public health? But I needed a break, and the donor who was funding us said, you go and take a break, go take a holiday. It's a paid holiday, go to Antwerp. But in Antwerp, I found people who were really, concerned and passionate about making a difference in that time it was called the third world countries, and not just going there and collecting data and doing this thing. And they treated us like equals. Among the 40 students, we were nobody from third world, first world, etc. So that made a lot of difference. And that is one of the reasons why I continued the relationship with this thing. Having said that, I have had experiences with many other institutions, and I can't say the same for the other institutions.
Well, I think I missed asking you about your WHO experience. I mean, you worked with WHO country office for a long time. Was this a significant shift? Probably you shifted from the tribal areas to the WHO. Isn't it? Yes.
Yeah. So yeah. Working in Goodloor, I realized there was a lot of things that we could change, because like I said, when we started our work in Goodloor, the maternal mortality rate was in the range of 500. Infant mortality was more than 150, this thing. And within, by 5-6 years, maternal mortality had come down tremendously. Infant mortality had come down to less than 25. And both my wife and I said, hey, if we can do it in this place with limited resources, why can't the government of India and the state governments do it everywhere? So that was a naive assumption. And then 10 years after Goodloor, we said, let's go and start working at Delhi to make changes in the policy level. And I was lucky. There was a super cyclone in Orissa. So I went out there for this thing work, for relief work. And then the WHO saw me working there and said, oh, you're very good. Why don't you help us, join us? And I worked in Orissa for 1 year, and that was fantastic time at the state level. But then they promoted me to Delhi to say, do the same thing in other states. And that's when I realized that working at Delhi is you can't make too much of a difference working at Delhi. You are just one small cog in a huge wheel, and there are too many players who are pulling and pushing and whatever. And so after 2 years in Delhi, totally 3 years in WHO, I put in my papers and I came back saying that I think the best place to work is in at the state level. And that was also the time when this idea of the Institute of Public Health came in. So 3 years. I'm not saying WHO was bad, but I learned a lot because I had an opportunity to travel across the country and see various health services working with the government, etc. But I was not able to do many of the things which I thought I could do at that level. Yeah.
Yeah, I mean, it was interesting to listen to your experiences, in a tribal hamlet, and then moving to the WHO country office, and the work that you did with the integrated disease surveillance program. If I am right, you work with developing the surveillance system. What we see nowadays, every state is making use of that system, which you were part of in the beginning. So, I mean, this disease surveillance system in India and in many countries is still having a lot of challenges. And being a person, I still remember, 15 years back, you teaching us your experience with the surveillance system, developing the surveillance system. And so looking back, how far we progressed, over these 15, 20 years, when we had a lot of technologies coming up, which would have helped us improve the surveillance system. Could we make use of these systems, or the huge investment that came out even in this period?
Yeah. So, pardon me for being pessimistic and skeptical, but what in the beginning, at least the surveillance system which I kind of learned was from Orissa. With my colleagues in the department there, we set up a system after the super cyclone on weekly basis, reporting, etc. And that worked. Then from the 6 districts, it expanded to all the 30 districts of Orissa, and it still worked. And people started talking about it. Now, which is why I was pulled into the Delhi to say now, okay, Orissa is done. Now you do it in the other states. Problem of scaling up is that we forget the essential thing of anything, which is human. The human element. It's not so much about technology, but so much of, like in Orissa, we had a team every Friday evening. That team would be looking at the reports coming in from the 30 districts, would be able to identify if there was any spike in any of the disease conditions, and would immediately call up. That time we didn't have email, WhatsApp, etc. It was just a phone call. We would immediately call up the district or the block health officer and say, hey, listen, what is happening? We noticed this thing. So there was data collection from this thing, but also there was somebody looking at it, this thing. The moment it became IDSP, and that time World Bank was funding it, and World Bank said this has to be digitized, so everything will come through computers. And many of us said, listen, there are no electricity, there's no internet in the villages. How will our sub-center staff this thing? They can still use fax machines, so let's keep it like that. But no, that's why I said many of the things we couldn't this thing. So they started digitizing, and IDSP started coming in on a weekly basis, etc. Problem was there was nobody to look at it, either at the state level, national level, or the district level. So data was coming in, nobody was looking at it, and then garbage in, garbage out. So, which is one of the reasons, I mean, if you look at today's COVID thing, actually the NCDC should have been managing the entire COVID. Why is Niti Aayog and why is ICMR handling COVID with this thing? Because NCDC, there's an entire epidemiology and epidemic cell whose only job is to monitor these sort of things, and they have a team there as well as at the states. But unfortunately, that is so one thing, that we depended too much on collecting data but not on analyzing it. So actually today we have the technology, because we have artificial intelligence, we have machine learning. So it is possible that we can have software which will look through the things quickly and say, hey, in this village, in this taluk, there is a spike of fever or diarrhea, alert this thing. I don't know whether we have reached that stage yet in CDC. I've been a little out of touch of that, but it is possible. But ultimately, it is the human, the person behind those computers who need to use their mind and say, yes, this is what we need to do. And without that, I'm sorry, whatever technology we have is not going to help.
I think you made a big...
Can I just give one more example?
Yep.
See, when we learned about surveillance, we said there are 3 arms in surveillance. One is the clinical arm, second is the epidemiology arm, and the third is the laboratory arm. Yeah. So the team should have these 3 competent people, a physician or a whatever, epidemiologist and a laboratory person going into the field to collect the data and then come together, sit together and discuss what is the thing. But today, if you look at the way epidemics are investigated in India, the clinicians arm will come from All India Institute of Medical Science. They will come, they will parachute in, take interview some people, examine the patients and go out. The laboratory people will come from NIV Pune, will take some specimens, go out. And the epidemiologists will come from NCDC. So there's no meeting, there's no talking, because each of them are in their little silos. So that's what I keep on emphasizing. For surveillance to work, you need a team approach. You need people to this thing. It is not, technology will not be enough for this. Maybe I'm old-fashioned.
I think that's an absolutely clear point, and the clear definition of surveillance itself is like you make use of this data and try to make changes using that data, and it's a circular way of using the data. But unfortunately, it's all ending as a survey, as you rightly mentioned. You had this experience of working with international universities. You mentioned your PhD, and even now the Institute of Public Health Bangalore is I would say that when many big institutions in the country are struggling to have partnership with global institutions, a relatively smaller institution like yours could continue this partnership with multiple institutions producing PhDs. How was that experience on working with international universities, the regulatory environment, and also the interest of our students in that approach?
Yeah, so I would say that, we were lucky to start with that partnership with the Institute of Tropical Medicine, where there were faculty there who had spent decades working in Congo hospitals and health centers, etc. So they understood what we were trying to do. So that was a very important learning for us. Important aspect of this collaboration, because they treated us as equals. There was never any issue of this thing, of your third world, we are first world, or your south, we are north. That sort of thing was never there in that faculty, which I'm not saying in all the faculty of Institute of Tropical Medicine, in the public health department I'm talking about. We have had these things with other universities, with Leeds University, with Maastricht University, etc. There, the interactions were by the time we started establishing these other collaborations, we already had established ourselves in IPH as somebody who are serious, people who are serious and doing quality work, both in terms of research and training. We had a bunch of young researchers who were really passionate about public health, and they were publishing, they were doing a lot of work which really kind of was getting noticed. And so when other institutions came in, they respected us in the sense that they did not treat us as, oh, you do the data collection, etc. Like recently, not recently, last year, I had a very close interaction with a university from US, and they literally saw, this is not IPH, this was my current, my just recent HSTP, they saw us as data collectors. They say, you collect the data and give it to us, and we will analyze, and we will publish, and you will be a co-author in that. And we said, no, that's not the way it works. We will ask the questions, we will this thing, but they could not understand that. They could not. So, but that is the way most of the universities, I would say, still among the American universities. I do not see it so much in the European universities, but I don't have much this thing. But among the American universities, I shouldn't be generalizing, but this is something that I really this thing. And they really respected our expertise, and we were happy to actually, like, we started the online, piloted the online classes. And I remember the faculty at ITM said, oh, online will not work. But then after 3 or 4 years, they realized that it can work, and this thing. So now they have copied this thing. They have taken lessons from us, and they have introduced online. So I think it has been a mutually learning experience as far as this thing goes. But the bottom line is, you have to be good. If you're not good, then people will ride roughshod over you.
Yeah, you started with physician in tribal area, then moved to the national, working in the national sphere. But then there are also interesting things like your IPH and your team had done a lot of work in urban health. Urban poor is again, in India is going to face a huge challenge in meeting the health needs of the urban poor. So that's also, maybe you can speak some of your experiences, which will be helpful for young scholars also to find, there are a lot of things to work on,
Yeah, no, absolutely. So when we worked in Goodlure, and subsequently for us, rural was the worst, this thing. But when IPH was started, and in fact, somebody said, why don't you go to the urban areas and look at what the situation is? We found that the situation was worse off in urban areas, among the urban poor, than the rural areas. Because the assumption was that, oh, these are people living in urban areas, there are clinics, private clinics nearby, there are hospitals nearby. So government kind of does not provide any services except maternity services, that's all. And those are very few and far distinct. So what happens is, the people, especially living in the slums and these things, they can't get access to routine immunization. If they are pregnant, unless they can't afford the private hospital, so they go to the maternity homes, government maternity homes, which are far away. Like, we have only 7 in the entire Bangalore. Of 10 million people, we have 7 this thing. So obviously it's not enough. And then, of course, the poor quality of care, etc. And most important, in a rural area, there was a sense of community. Whereas in the urban areas, because in the slum, you'll have some people who are from Andhra Pradesh living, then some Tamil Nadu, some Kannadigas. So there's hardly any sense of community as such. So it was very difficult for them to come together to talk about this thing. So actually, that was, I think today, like you rightly said, urban poor are going to be the worst hit, because at least in the rural area, there is some sort of health system working this thing. But in the urban areas, that is at present, though we have NUHM, etc., at present, we do not have a functional this thing, an operational thing which is effective. Unfortunately, there are not many people working in urban areas. If you look at it, most NGOs, even if they're working in the urban areas, they are talking only of preventive services and not much on comprehensive health services where people can get this thing. In fact, when we actually, my wife was the one who worked mostly in urban areas. She would be a better person to think, but we found very interesting things. Like, we found that actually the people return back from work at about 8 o'clock. And that is when you want your health facility to be open. But our government facilities all are there from 10 to 12 or 10 to 4 maximum. Nobody, the adults are not there. This thing, you want, most of the private clinics don't have basic facilities, quality these things. And we discovered, even when we are offering people in the urban areas, we were offering generic medicines, because then we can reduce the out-of-pocket payments. People were not willing to accept the generic medicines because they have been brainwashed by the practitioners, both government as well as private, saying generic medicines are cheap because they are poor quality. So, this sort of, it was a tremendous learning experience for us in those 8 years that we were there in the urban areas in Bangalore. Yeah.
And so I think it's time to take a couple of questions, at least from the participants. So one of the interesting things, even when you said about the tropical medicine, same is now with the case with global health. When in universities in the West, I mean, I am now based in Boston, so in many universities and in many conversations, global health is again considered as something which is related only to the South, the global South.
Yes.
Whereas we have seen COVID has exposed the vulnerabilities
Yes,
and deficiencies of all big economies that we were talking about for many years. So again, the definition of global health, the perspectives for global health is again something which the new scholars should be aware of. It's not something about the global South, but it's more about everyone in this world, right? So I mean, are there enough efforts in India to develop this as a stream? So that's one of the questions that came up.
Yeah. So actually, this entire thing, global health, is part of the move from tropical medicine. Then in the 80s and 90s and all, people said, why are you calling? Because historically, these were tropical medicine institutions, because the colonists would go to the Congo and to the India, etc. And if they felt sick, they would come to this tropical medicine center for treatment. That was the history behind most of these tropical. So they had specialized doctors who had trained in malaria and tuberculosis, etc., in these centers. Then, then people said, how can you have a tropical institute in Antwerp or in London, etc.? So slowly, many institutions started calling it, okay, we'll have international health. And then that became global health. But still the mindset was, we know y'all are the seekers of knowledge, and we will give you the knowledge, and y'all go and implement this thing. Which is why today, when I look at many of our public health institutions in our country, they have been tremendously influenced by the curriculum of these tropical medicine, global health, these things. So they have one thing on epidemiology and statistics, they have something on disease control, then they have something on nutrition and environment. These are the 4 modules, standard modules you look at most of the public health. Whereas in India, we want something very different. We want more public health management, because many of our problems are not about diseases so much as about how to better implement our policies. There's an implementation gap at the state level, at the district level, and we need more of that knowledge for our public health professionals. We need a knowledge of critical thinking, of asking questions. Why is this happening? What can I do to improve it? So these are the basic competencies that this thing needs. Unfortunately, global health is still seen as a thing. Now, what is happening? There's a new movement, which is now this thing I say, I mean, 30 years in this field, I've seen various phases. Now, the latest is decolonization of health. Yeah. So people are saying it should not be the colonial perspective. We should think it's very good if you are able to change your mindset. If not, whatever you call it, it will still be the same thing that we are. Because actually, COVID is a very interesting case study. Today in India, we are able to immunize in terms of lakhs per day, because we have a system in place which can do that. Whereas most other countries, you take Australia, you take Belgium has got a thing, Germany, all these countries, because they don't have this system, they're not able to catch up and do the kind of immunization. So they should be learning from us and saying, how do we do this sort of thing? How do we do the tracking of lakhs of people, the tracking and testing? So there's a tremendous amount of learning that they can happen from countries like us. But like I said, it is the mindset which needs to change.
Maybe I take one more question before we move to Nasser. So You said about this. You earlier mentioned about opinion-based policy decisions. We over many years we developed some capacity in public health institutions and professionals in the country. I mean, there have been a lot of demand to have a public health service or a health service, Indian health service system, maybe focusing only on specific tribal population as we have in the US in many states, or even as a general health service stream, like the civil services that we have, because this needs more both technical and managerial and leadership qualities to run such a huge system.
Yeah, I would agree totally 100% in this. I would not call it an all India service, because then what happens is that, I mean, I'm speaking from my experience with IAS officers, they always see Delhi as their end, this thing. They want to be in Delhi. So they are maneuvering this thing. Whereas if you say at a state, actually some states are already doing it, what they call a public health cadre, where you have a clinical cadre and a public health cadre. And the public health cadre is trained in how to manage the population-based issues, whereas a clinical cadre will be on the individual this thing. Tamil Nadu is a very good example. Maharashtra used to be, unfortunately, it's coming down. Gujarat is also building up to some extent. Orissa, I heard recently, has introduced a public health cadre. I think that is the way forward, because it is, I mean, this is something I've fought all my life. Most people think clinical surgeon is the specialization, or pediatrician is a specialization, but public health is common sense. So I've argued with health secretaries in Karnataka saying you need a specialist. No, what is that? It is common sense. No, you immunize, all the guidelines are there. You just do the thing. What is the big deal? And why do you need a specialized? Whereas a surgeon has to be specialized in operating. A pediatrician should know how much this. So that is a mindset not only of the policymakers, but right across. And this is one of the reasons why actually the medical fraternity has opposed the public health cadre, because they realize that suddenly a public health professional can become the director of health services, whereas a surgeon will not be able to become the director of health services. So they have been blocking. That is the politics behind this whole thing.
Well, there are a couple of issues which have been raised, here on the chat box. They are all related to your tribal experience. I think one issue is were you considered as an outsider when you worked in such a place, and the other issue is how do you mainstream they have their own system of medicine, they have their own culture. How is it possible to, I mean, you mentioned it, that it's difficult to integrate with the mainstream, but what are the difficulties that you faced when you were working in that?
Yeah, so let me say that in the beginning, now remember, the word Adivasi is not the same across the country. Huh? So there are Adivasis and Adivasis and Adivasis, because if you go to the northeast, the Adivasis are the majority in Assam, in Arunachal Pradesh, Mizoram, etc. So they are the majority, and the non-Adivasis are the same. So they have a different way of looking at things. If you come to, say, Chhattisgarh, Jharkhand, and etc., they are about 30, 40, 50% of the population, depending on the district. So again, there is a certain majority, the same. In Gudlur, they were definitely the minority. And they were also what the government today calls the particularly vulnerable tribal groups. I mean, for those who are not the same, it's like the people in Andaman and Nicobar Islands, the Adivasis there, because these were hunters and food gatherers who were suddenly in the 70s evicted out of the Mudumalai sanctuary and said, now Mudumalai sanctuary is only for tigers and elephants, not for human beings. And so these people were evicted out. So these people, the Adivasis, and when we went there in the 80s, they were totally suspicious of anybody from outside. So I remember in the first few weeks or months, actually, when we used to, Jeep would park at the road, and then the Adivasi hamlet was right on the top. We'll see them watching us as we are climbing up the hill. But by the time we reach the hill, there's nobody. people have vanished into the forest. But because we started working with the tribals, not only on health, but also on their forest rights, and so we were engaging with the entire community, slowly a trust was being formed. Second is, I think our health workers, village health workers, did a tremendous gap in bridging this thing. So I would say, if you're working in tribal health, one of the human resource you will need is a community health, village health worker who's able to interpret what you're saying to the tribals and what the tribals are saying to us. Because A, we don't know the language. 10 years, this thing, we understand their culture to some extent. I mean, but I'm sure it is not the same as Adivasi woman living in a village. She will understand much better than us. This thing. So I think that is the village health worker, then later the health nursing assistants and the nurses. All of these, in fact, one of the reasons why people, the Adivasi started coming to the Adivasi hospital was because they said, here I can tell my problem in my own language. That makes so much difference for them. So this was one thing. There are many other things which we did, including we never had beds. Because when we were starting to make the hospital, the people said, the community said, we are afraid of lying on beds because we fall off the beds in the hospitals. And so we don't sleep in the night. We are sitting there on the bed, and then next day the doctor says, oh, you're not looking good, you're worse, so increase the injections or whatever. But actually we have not slept. So the first few years in the Adivasi hospital, we never had beds. We just had mattresses on the floor. Not good for the doctors and nurses' backs, but it was very good for the people. So that was one of the thing. Then the second question was, sorry, Professor Nair, what was the second question?
Is it possible to mainstream? I mean,
mainstream,
say for instance, Jharkhand, they have their own system of medicine. I mean, how is it possible to mainstream that?
So this mainstreaming is a very, normally we talk of mainstreaming is, we ask the Adivasis to change their system into the mainstream society. But we at Goodloe, we said it should be the other way around. The mainstream society should change to the needs of the Adivasis, because they are the minority and they need more support. And there are 2-3 things which we did, which this thing. So we failed miserably when it came to herbal medicine, because we said, okay, if the health worker knows any herbal medicine, please give it. We are not stopping you. But we ourselves did not promote it actively, because we said we don't know. We knew, yes, Panipurka was given for fever. This was given for that, this thing, but very superficial our knowledge was. So we did not promote it ourselves because we did not have the knowledge. But then the message which went out later, I mean, 6 years, 10 years later, we realized in hindsight, was that the message was that the doctors are not promoting this because it is not good enough. So that is something disservice we did for the Adivasis in Goodloe. But when it came to, say, one thing which we used very effectively was the hospital. The Goodloe Adivasi hospital, 10 beds with a surgeon, a gynecologist, and 2 duty doctor generalists, was not available in that entire Goodloe taluk. We are talking about 7 lakh population. There was no such hospital. The nearest hospital with such specialization, which a theater and a labor room, etc., was all 2 to 3 hours away. So then the non-tribals wanted to use the hospital, saying that, this is Adivasi hospital, fine. You see the Adivasis, but see also us, because we also have to go to the, we also fall sick. We are also human beings, etc. So what we did was, we said, you get permission from the Adivasi Sangam before getting admitted. For emergencies, no such permission. You got a ruptured uterus, or you got a fracture, road traffic accident, etc., no such thing. But if it's an elective procedure, elective cesarean or a elective hernia operation, etc., you have to go to the Sangam office, get permission from the Adivasi leadership that this is, you can admit this patient into Adivasi hospital. So what happened was, suddenly the power dynamics changed. And suddenly the Adivasis were seen as more powerful than the mainstream. And that is how we brought in the mainstream in terms with the Adivasi terms. So we had, I mean, our health workers would come back in the monthly meeting and say, you know, I go and work every day for this whatever farmer. And yesterday he came and he was speaking so nicely to me, and he said, Sharda, will you please give me a letter of permission so that I can admit my daughter to your hospital for delivery. So that power equation changed, and I think that is what we have to talk about. Mainstreaming the minority into the majority is very easy, but then the minority loses their identity, their culture, etc. We should try and do it the other way around.
With respect to COVID, I mean, are you familiar with what kind of, what is the status of COVID among these tribals? I mean, there's one question on that. I think the vulnerability of these people, I think that's an important issue.
Yeah. So again, so the health, though, I mean, my wife and I left 10 years later, the health program continues, the development program continues, there are other doctors and this thing, so everything continues. So one of the things which happened was in the first wave, because a lot of people had gone to Coorg for coffee plucking, etc. And so they were coming back and they could have been probably exposed. So there was at the village level, there was screening. So you come in, you don't enter the village, you stay outside in the Devapara or this thing for 5 days. So it was a community quarantine kind of thing. But in the second wave, people had traveled all over the place, so there was not much this thing. But everywhere, people started noticing marriages, funerals. These were the common reasons why people were getting COVID. So messages went around, don't go for marriages. But again, among tribal culture, this is a very important occasion. So they were not very successful. But what happened was the government of Tamil Nadu approached the accord and this thing, saying that we need to immunize the tribals, but they are not refusing to cooperate with us. Can you all help us out? And then the area centers, health workers all got into the act, and we accompanied the PHC medical officers to all the villages. And the accord was given the Adivasi Sangam was given an award recently by the Chief Minister for the first district which had more than 80% immunization among the tribals. So that is, whereas we are talking about vaccine hesitancy, etc. And this is, I think, mostly because of the trust that people have on the system.
Yes. Yeah, the last question, I think, today's younger generation of public health scholars, you are familiar with many of them. I call them as bullet point generation because they're happy to learn everything on bullet points. And perhaps, unlike many of us, reading is a major casualty. I think people don't read books, or they're even not familiar with many of the titles that we mentioned. And of course, the exposure like you had gone through, I think that's very, very important. Do you have any specific message to the younger generation of public health scholars?
I mean, these are messages that I learned from my experience, this thing. One is keep people in the center, wherever you're working as RM and CHA consultant, or you're doing some research on something, keep always the people in the center. What my work, how will it affect the people? Can I talk to the people? Can I understand their perspective, etc.? Do not, again, I repeat, do not take illiteracy or semi-literacy as equivalent to incapable. They are capable. They have tremendous understanding. They can grow their own food. They can repair their own house, which you and I can't do. So treat them as equals. Just as Professor Nair was saying, how do the international universities treat us? If we need to treat the people, the community as equals. That is the first thing I would say. The second thing I would say is keep thinking mind. Many times we accept whatever guidelines is coming from the top, from Delhi, from WHO, UNICEF, etc., as the holy grail. It is not. It is made up of people like us who don't even have the exposure to what the district or the state where you're working. So think, is this appropriate for our thing? So thinking mind is very important. Many people ask me, Vesh, I want to get into WHO. We have interns coming in at IPH and they all say, I want to work at WHO. How do I get into WHO, UNICEF? And I say, at WHO and UNICEF, you are just a secretariat. You will be just looking at proposals, you will be passing files, etc. You won't be doing anything real. If you want to do something real, go to the districts. Join as a district epidemiology officer, as a district TB consultant, etc. That's where the real work happens. That's where public health you can learn from, experience it, and then you can this thing and go up maximum up to the state. National level, I wouldn't advise you to go. Even for somebody who's got so much experience, I would say national level is a quagmire. Well, very little, unless you have got tremendous political pulls, this thing, nothing happens. The third thing, which is a little controversial, but which I would like to, this thing is the fact that most of us were taught preventive care and curative care as two different silos. And we were said preventive care is good, curative care is not good. Okay, it is there, this thing. We forget that even in Alma Ata, when they talk of primary health care, there was two elements of curative care in that. One is care for essential services and referral services. Both were related to the thing, but these were very conveniently forgotten, and we talked of water, sanitation, immunization, ANC, etc. But for the community, this is not this is an artificial divide. For them, it's a continuum. I will come to you for immunization, but when my child falls sick, please look after that child. I will come for antenatal checkup, preventive medicine. But when my wife, when I need a cesarean because there is an obstruction, please make sure I get that cesarean. So this artificial divide, which is created by most of us public health people, I think is something I would leave with the youngsters today. That's it.
Well, thank you so much for your rich insights and reflections. I think, I'm sure this will help in developing our own perspectives, especially the younger generation. And thank you so much for giving this time. I know it's very important for future of public health that people like you should be reflecting on what is happening in the past, what has happened in the past and what is happening now. I think it was really great. And I just want to make one announcement. The next person in the series is Professor Irudaya Rajan. I think many of us know as a very well-known demographer and the migration expert in the second week of August. I look forward all of you to be there in the next session also. Shafi?
Thank you, Dr. Deva, for joining us today. If I want to take one message from what we discussed today, it's about trust. The word is trust. Recently I was part of a global commission which is working on taking forward the social determinants globally. So yeah, we are all narrowing down to one theme of trust. You very clearly mentioned in your last sentence, you lose the trust of the community when you don't provide them their essential services, but you go behind them with whatever you want to provide. So this is the bottom line of or the key message that I would take from you from this conversation. I think this is a very, very strong message globally and relevant nationally as well. Thank you so much for taking your time to join with us and talking to the public health community.
Thank you very much for this opportunity, and I look forward to your other sessions also. Please keep me in your mailing list.
Yeah.
Thank you. Sure. Thank you.
Thank you.